Okay. So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have with us Dr. Rajesh Kantharia, who is not an unknown person to us because he has been a regular guest speaker in this club when it was offline, as well as during our online years of this holding the meeting. So, to briefly introduce him, he is a head and neck oncosurgeon based in Ododara, and he has 25 years of experience. He has been teacher and mentor to 25 fellows under FHNO fellowship program, and he has several publications to his credits in index journals. He has been principal investigator in head and neck cancer trials. He is executive member of the Foundation for Head and Neck Oncology, and obviously he has been invited as speaker at national and international conferences several times. And his current affiliation is Banker Super Speciality Hospital, Vadodara. Today, he is going to talk about lymph node metastasis in oral squamous cell carcinoma and overview. So over to you, Dr. Rajesh Bhai. Thank you once again for joining us. You have about 40-45 minutes to talk, and we'll have some 10 minutes of discussion. Over to you.
Thank you, sir, for the kind introduction. So, good morning, respected teachers, seniors, and colleagues. At the outset, I should thank the members of the Saturday Club to giving me this opportunity to present a talk in front of this august audience. We just observed the World Cancer Day on 4th February, and I'm fortunate and I should thank Satish Bhai to allow me to present in this month, which we all, this month we all have awareness programs on cancers and screening programs on various cancers, which are, Indian cancers. So today I'll be talking on the management of lymph node metastasis in oral squamous cell carcinoma. And I will try to present a basic overview of the lymph node metastasis. So I hope you are able to
Yes.
see. So
Yes.
this is my first slide. So my presentation is lymph node metastasis in oral squamous cell carcinoma, an overview. I am a head and neck oncosurgeon, currently affiliated with the Banker Group of Hospitals, and we are based in the Banker Super Speciality Hospital at Manjalpur. Now, in this talk of mine, in this 30 to 35 minutes, the time which I am allotted, I'll be talking about basically oral cancer, the incidence, the mortality, and the financial burden which comes along with this cancer. I will be touching on the tumor cell invasion, the pathways mainly, something about the physiology, the lymph node, and how the metastasis occurs at the molecular and the anatomical level. Some anatomy about the cervical lymph nodes, what oncologists, what we refer to as levels of cervical lymph nodes, the TNM staging, which we all apply during our clinical and pathological staging of the disease. We will have a brief talk about how the node positivity affects the or impacts the staging and the survival rates, and how the depth of invasion of the primary tumor affects or impacts the node positivity. Then something about the management of lymph node metastasis, the milestones which are important, and 2 or 3 slides about neck dissection, what is a neck dissection, the types of neck dissection, and most importantly, the management of a node negative neck. That is what we will cover. And briefly, I will review one landmark paper which is again Indian origin paper, and some newer techniques which we are now using for the management of N0 neck. So this is how I'll cover my talk. Now, if you see this global scenario, this is India, and you can see this is something which is 2020 data. This is a Globocon data, and you can see India in the last 3 years, this shade has increased and it has become more darker. So you can see the burden which India has when it comes to oral cancer. Now, this is the main and the root cause why we have increasing number of cases of oral cancers in India. And this is in spite of the warning and the government uh, what they have done for the gutka and the cigarette and bidi smoking. Now, if you look at this Globocon data, which is 2022, and you look at the top 5 most frequent cancers which India has, both males and females, lip and oral cavity tops the list, followed by lung, esophagus, colorectal, stomach, and other cancers. If you see the female scenario, breast, cervix, uteri, ovary, lip, and oral cancer. So you can understand lip and oral cancer is the major or the most frequent cancer in males in India. Now, if you see this prediction of WHO, the incidence of oral cancer will increase by around 50% from 2020 to 2040. And the projected incidence of oral cancer is estimated to be 1 in 60 people. And most likely Indians, the younger age, will be diagnosed with oral cancers. Now, if you look at the mortality of the cancers, again, the top 3 leading cancers when it comes to mortality in males is lip and oral cavity, lung, and esophagus. And in the females, it is breast, cervix, uteri, and the ovary. But when it comes both combined together, breast, lip, and oral cavity. So again, lip and oral cavity tops even the mortality or the number of deaths occurring due to cancer. So this is the sad part. The mortality rate for oral cancer in India has not improved over the past 3 decades. And the estimated number of deaths are around 50,000 deaths from oral cancer each year. Now, one point which I want to stress is these deaths or these numbers are only recorded numbers which go into the registry. There are nursing homes, private nursing homes in India, where a lot of cancer patients are treated, and all these patients go unnoticed or they are not registered in the registry. So again, this number is almost double or 2.5 times of what we have as a data. If you look at the survival rate, the 5-year relative survival rate from oral cancer is around for 50% after treatment. But the good part is, if it is diagnosed early, the survival rate is much higher. Now, how the clinical staging affects the survival rate of oral cancer. So if you look at the clinical staging, if it's an advanced cancer, say stage 3 or stage 4, the survival rates drop to 40 to 60% in stage 3 and around 20 to 40% in stage 4. Now, this is a very important slide which looks at the financial burden or the patient's financial this thing after or when he or she is diagnosed to have a disease. Again, if you see stage, advanced stage 4, 3 and 4, the cost of total treatment will be around 2.5 to 3 lakh of rupees. And this is, mind you, a TMH study, and this is something in a hospital which gets government grant or say the recent Pradhan Mantri Yojana or the PMJ Yojana. Now, if you go to a private setup, this cost of treating a stage 3 or 4 oral cancer will be 5 to 10 times more. So, in a private or a corporate hospital, the cost of treating the entire cost, surgery followed by adjuvant treatment, will be around 7 to 10 lakh of rupees. So this again is a very important slide, and again a very important topic which we might discuss sometimes later. Now coming on to the physiology or the pathway, how the tumor cells invade or the primary tumor invades the nerves and vessels to grow. So what happens is if you have a tongue cancer, it will locally grow and erode the connective tissue, the mandible, and then it will spread to the regional lymph nodes through the lymphatics, and there is a distant spread also which will happen through the arteries and the vein. So this is how a primary tumor would involve or erode the surrounding structures. Now, if you look at the lymph nodes and the metastatic pattern to the regional lymph node, what happens is this is the tumor. These are the lymphatic channels or the vessels. So the first node which gets involved is the sentinel node. And through the sentinel node, the regional cervical lymph nodes get involved. Then the spread is through the thoracic duct, through the left subclavian vein, and then it goes to a distant organ. Mostly it is the lung, the liver, or the skeletal system. The other spread which occurs is through the blood vessels, where it goes directly into the lung or the liver or the vertebra. So this is how the primary tumor will spread into the regional lymph nodes or into a distant metastatic site or an organ. This is the molecular pattern of lymph node metastasis. So we call it as a pump principle, where we have 4 stages. The first stage is preparation, which involves the induction of tumor immunosuppressive microenvironment by tumor releasing factors, promoting lymphangiogenesis and vascular remodeling. Ultimately, it leads to the formation of pre-metastatic niche for lymph node metastasis. The next step or the stage is unleash, which refers to decrease in addition between the tumor cells, leading to their detachment and migration towards lymphatic vessels. The third stage is migration, which is guided by chemokine gradients, allowing cancer cells to breach the lymphatic endothelium and enter the lymphatic lumen. And the last stage is planting, which refers to the settlement and proliferation of cancer cells within the lymph node, leading to lymph node metastasis. Now, coming back to our anatomy textbooks, this is the picture of cervical lymph nodes, And we have all these named lymph nodes starting from the preauricular, the parotid, submental, submandibular, the lower cervical, supraclavicular, and the posterior triangle lymph nodes. So this is something which we are very familiar with, and we refer to when we say the neck nodes are involved in the neck. But as oncologists, it becomes easier to have a level of lymph node in the neck so that it is uniform. The uniformity is maintained. So when I talk about levels of lymph node, all my colleagues who are practicing head and neck oncology would understand level 1, 2, 3, 4 in a much better way rather than the named lymph nodes. So what we have is level 1, 2, 3, 4, 5, and 6 in the neck. So level 1 is submental and submandibular lymph nodes. Level 2, 3, and 4 are upper, mid, and inferior jugular nodes. Level 5 is posterior triangle group of lymph nodes. And level 6 is anterior compartment lymph nodes. Mainly, this anterior compartment lymph nodes will get involved from cancers of the thyroid gland and the laryngopharynx. So this is how we would refer when we talk about the involvement of neck nodes in our as oncologists. Now, if we look at the anatomical patterns of lymph node metastasis, as oncologists, we know when the level 1 is involved, the primary should be in the lower alveolus. Level 2, 3, and 4 involvement would guide us about the primary where it is going to be in the tongue. The upper oral cavity will drain into level 2B, and the buccal mucosa will drain into level 3, 4, and level 5. Sometimes this becomes important when we have trismus. Clinically, the patient is not able to open his or her mouth because of fibrosis. This lymph node involvement will guide us where the primary will be. So again, it is very important to know the levels so that we can look at the primary sites of the tumor in the oral cavity. Now, this is a very important slide. This is how we stage the node, and this is the TNM staging of the node. So I'll just go through it fast. N0 is a node a neck which is node negative. So clinically and radiologically, there is no node which is visible. N1 is a node which is less than 3 centimeters in size, and the node stays within the capsule. N2A is a node which is 3 to 6 centimeter in size. Again, the node is retained within the capsule. N2B is multiple nodes, more than one nodes, each node less than 6 centimeter in size and within the capsule. N2C is a node which is there in the contralateral neck, is N2C, again less than 6 centimeter in size and within the capsule. N3A is a node which is more than 6 centimeter in size but retained within the capsule. So there is no extracapsular spread. And N3B is any size of node which has breached the capsule and it has become extranodal. So there is an extranodal extension is N3B disease. So this is how we stage the nodal disease in the neck. Now, how node positivity impacts the staging and the survival rates. So this is again the same slide, but if you look at this, stage 1 and stage 2, when the node is negative, so you don't have a node which is there in the neck clinically and radiologically, the cure rates or the survival rates are around 80%. But we have a node which is positive, N1 node. That means the node size is less than 3 centimeter. But once we have this node, the stage becomes stage 3, and the survival rates drop from 80 to 40 to 60%. A node which is more than N1 in size, the survival rates drop to 20 to 40% and it becomes stage 4. So, how node positivity will affect the survival rate is very important. So, a node positive neck, even if it is a small node less than 3 centimeter, you should not expect the survival rates more than 60%. And it is worse if the node is more than 3 centimeter. So this is again very important when you have to explain the prognosis to the patient. Now, how depth of invasion of the primary tumor impacts the node positivity. So in the previous slide, we saw about the node positivity, how it impacts the survival rate. Here we have something which is depth of invasion and how it impacts the node positivity. So if you have a neck which is clinically and radiologically negative, but if the depth of invasion is more, then there are chances you will have occult metastasis in the neck. Now let me explain you how we calculate the depth of invasion. So this is the tumor and this is the basement membrane. This is some pathology for you. This is the basement membrane. So any tumor which is above the basement membrane is the exophytic component of the tumor. And the tumor which is deep to the basement membrane is the infiltrative component. So the depth of invasion when we calculate from the basement membrane to the extent where the depth is. But when we calculate the thickness of the tumor, we take the whole tumor. We take the exophytic component also to consideration. So this is how we calculate the depth of invasion. Now, depth of invasion to calculate by scale or by palpation is very difficult in your clinic. So what we calculate is, how we do it is on a MRI, we see how the depth of invasion looks like, or the MRI will give us a hint what is the depth of invasion of the tumor. And this will guide us whether we should address the neck or manage the neck along with the primary or not. We will come to this in a while and I'll explain you in a much better way. Now there is some data which was published by the MSKCC group in New York, and this is old data, but it says even if your tumor thickness, even if your tumor is say stage 1 or 2, the chances of node positivity is very high. So what they did is they divided the tumor into 2 millimeter or less, 3 to 8 millimeter, and more than 8 millimeter. The thicker the tumor or the increase in the depth of invasion of the tumor, you can see the overall incidence of nodal metastasis. Less than 2 millimeter, 13%, 46% for tumors which are 3 to 8 millimeter in thickness, and around 65% when it is more than 8 millimeter. So mind you, even if the stage of the tumor is stage 1 or 2, you are likely to have neck node metastasis in the neck at this rate. And if you see the number of patients dead of disease, even with tumors which are 8 millimeter or less than 8 millimeter is size, is significant. 35% is the mortality rate when the tumors are 8 millimeter more or in thickness or more than 8 millimeter in size. Now this is my own data, published data, where we also looked at our depth of invasion, and all these tumors are less than 1 centimeter in size. So what we did is from 1 to 10 millimeters, we have the total number of cases, and this is the presentation. On presentation, out of 109 cases, 16 patients had node positive, even though the depth of invasion was less than 1 centimeter. The number of cases which had occult node when we dissected the neck was around 8%. And if you combine both the positive cases at presentation and the occult nodal metastasis, we also have a rate of around 25% in tumors which are less than 1 centimeter in thickness or depth of invasion. So again, our data also suggests that the pathological positivity of nodes when you have thin tumors is around 25%. Now, let us look at the rates of lymph node metastasis in different sites of oral cavity. So if you see all the subsites of oral cavity, whether it is retromolar, trigone, tongue, floor of mouth, buccal mucosa, upper oral cavity, lower alveolus, the rate of lymph node metastasis is about 25%. So this is again a Chinese data, but it correlates with the world literature and our own patients also. Now, coming on to the management of lymph node metastasis, this is the timeline or the milestones which are very important. So the awareness of the importance of nodal metastasis we have since 1790s. In 1810, the theory of 5 distinct phases of lymph node metastasis was developed. Now we have from 5, we have moved on to 4 stages of lymph node metastasis. Warren was the first who performed a neck dissection surgery in 1837, and Kreil developed a proper technique to do a radical neck dissection in the early 1900s. During the World War I and II, radiotherapy was first used as a treatment of oral squamous cell carcinoma and its lymph node metastasis. Small field radiotherapy was used for cervical lymph node metastasis. Suarez was the first to develop a functional neck dissection, which we will talk in our coming slides. Chemotherapy was first used in the 1960s as an adjuvant for lymph node metastasis. Dr. Shah performed a first large-scale study on the probability of lymph node metastasis in oral squamous cell carcinoma, which I just touched on in the previous slide. And role of lymph node in tumor immunotherapy is very recent. Now we come on to this management of neck. Now, if you look at the management of neck, surgery is the mainstay of treatment when it comes to managing oral cancer and the neck in oral cancer. We have seen that neck node metastasis is the most important prognostic factor after the stage of the tumor. And thus the management of neck is very vital. Now, when we talk about management of neck, the first thing comes is the imaging. How a lymph node will look when we perform an imaging. And this is something which is constant for ultrasonography of the neck, a CT scan of the neck, and MRI of the neck. But yes, MRI and ultrasonography will score over CT scan when it comes to looking at the neck nodes. So you have reactive nodes and metastatic node. Metastatic nodes are enlarged. They have an indistinct hilum. They have eccentric cortical hypertrophy, and there is central necrosis which is present in the node. So all these features you will be able to pick up on sonography or on MRI, and this will help or guide the surgeon whether to address the neck and what is the extent of the neck dissection which is going to perform. Now, this is something which we do, and this is how a neck dissection is performed, and these are the structures which are removed when we perform a neck dissection. So when we come to the classification of neck dissection, it was not standardized until 1991, and the the Academic Committee of Head and Neck Surgery and Oncology then published a standard classification system. Now, the classification goes that there are four types of neck dissection. Radical neck dissection is a standard basic procedure for the cervical lymphadenopathy against which all modifications are compared. And modification of radical neck dissection includes preservation of any non-lymphatic structure, and it is referred to as modified radical neck dissection. A selective neck dissection is when you dissect a group or levels of lymph node, and an extended neck dissection is when you remove additional lymph node groups or non-lymphatic structures which are additional to the radical neck dissection. So this is something which is a radical neck dissection. You remove all the lymph nodes and non-lymphatic structures from the lower border of the mandible up to the clavicle, the posterior border of the trapezius, and the midline. And this is something which is the extended radical neck dissection, when you have to remove the skin which is involved in the neck, or you remove part of the carotid and then graft it. Modified neck dissection is when you preserve one of the three important structures. The three important structures which we preserve in the neck when we do a neck dissection is the internal jugular vein, the spinal accessory nerve, and the sternocleidomastoid muscle. So when you preserve one of these non-lymphatic structures, it is called a modified neck dissection. Now, when you preserve all these three non-lymphatic structures and you remove a group of lymph nodes, it is called a selective neck dissection. It is lateral, anterior, and posterolateral neck dissection, where you remove or you dissect selective lymph nodes. Now we come to the most important thing, is how you manage a N0 neck or a node negative neck. Management of N plus neck is a no-brainer. You have to address the neck and you do a modified neck dissection when there is a node which is positive in the neck, like this node which is positive from a cancer of the gingivobuccal area. But what you will do when there is a small tumor on the lateral tongue and the node or the neck is negative, both clinically and radiologically? Now you got three options. Either you observe, so you just remove the tumor perorally and you observe the neck. The second is you stage it. When you are observing, you will stage it by sonography or other imaging modalities, or you treat the neck electively. So you do a elective neck dissection for a tumor which is small, or when there is a node which is not palpable clinically or radiologically in the neck. This is how a node or imaging would look when you do a CT scan of, this is a contrast and then CT scan of the neck. These are the levels of the lymph node, and this is how it will look when you see a CT scan. It will help us to know exactly which level of lymph node is involved. Now, when you have a clinically N0 neck, this is the neck dissection which we perform, and this is a selective neck dissection which is called supraomohyoid neck dissection. And it is done primarily, it is done for lesions or a primary which has got more than 20% risk or greater than 20% risk of occult nodal metastasis in the neck. And it is also done for squamous cancers of the oral cavity, where you have a small node at level 1 which is less than 3 centimeter in size. So when you address this levels, level 1, 2, and 3 are the neck levels which we remove when we do a supraomoid neck dissection. And by doing this, we remove almost 91% of the nodes which are likely to get involved even if the neck is negative. This is a landmark paper which is published by the TMH group. So this is something which is evidence-based, which we practice. So you remove level 1, 2, and 3 even if the node is not palpable, and you then subject this nodal disease or this specimen for the final histopathology report. Now, why we do the supraomoid neck dissection is because of this landmark paper. We were doing this neck dissection since say ages, but there was no evidence. There were case reports, there were studies, there were series, but there was no evidence. This is a landmark paper which was published in NEGM, and this says elective versus therapeutic neck dissection in node negative oral cancer. So by elective, what we mean is you treat the neck along with the primary tumor at the same sitting or during the same surgery. And therapeutic neck dissection is you observe the neck, you do the primary tumor, you observe the neck, call the patient for follow-up, and then you operate on the neck when the neck node develops or when the neck node or the regional metastasis happen. So what they did is around 500 patients, both stage 1 and stage 2. Tumors were mainly tongue and buccal mucosa, stage 1 and stage 2 tumors. Now look at this overall survival graph, the elective surgery group and the therapeutic surgery group. The disease-free survival graph, the elective surgery group and the therapeutic surgery group. Both the overall survival and the disease-free survival better in the elective surgery group. Now, if we go into the detail of this thing, in the elective surgery group, the overall survival rates were better. They were around 80%, and the therapeutic surgery group, it was around 67%. The 3 years disease-free survival group in elective surgery was 45%, was around 70%, and the therapeutic surgery group was around 45%. The nodal recurrence or the patterns of recurrence in therapeutic or the patients who were observed was around 74% chances of recurrence in the neck, which is very high. Now, what the results show is there is an absolute survival benefit of around 12.5% and an absolute disease-free survival benefit of around 24% when you operate the neck electively. What does this mean is if you treat 8 patients with elective neck dissection, you are preventing 1 death. And if you treat 4 patients with elective neck dissection, you are preventing 1 recurrence. So this is very important. This study was stopped in between because of the number of deaths which happened. So you have a survival or a disease-free survival only of 3 years. So now summarizing the management of N0 neck, what we do is a prophylactic neck dissection for patients who are clinically node negative, but they carry a high risk of occult node metastasis. We offer a elective neck dissection treatment for that. In elective neck dissection, what we do is a supraomoid neck dissection where we remove level 1, 2, and 3. And this is a very effective treatment to control the regional disease in N0 neck. Close observation is one thing which we only do for very thin tumors which are less than 4 millimeter in depth, and this treatment or this option requires a great compliance from the patient and again the expertise from the physician. So the patient has to be compliant for follow-up every 1 month, 2 months, and when the physician calls him or her. For a N plus node or node positive neck, you always have to do a neck dissection. If there is a small node which is less than 3 centimeter at level 1 or level 2, you just do a selective neck dissection and remove the levels from level 1, 2, and 3, or sometimes level 4. If you have a node which is more than 3 centimeter in size, minimum you do a modified radical neck dissection. Coming on to the adjuvant treatment for neck, for the sake of completion, you have to treat the neck after surgery by radiotherapy or radiotherapy with chemotherapy when there is a node which is positive at one level, when there are multiple nodes which are positive. When there is extranodal extension, you add chemotherapy to the radiotherapy also, and nodes which are more than two nodes which are positive on histopathology. Now, coming on to something which we can do, which is less than a neck dissection. Because if you see, even if you do a supraomoid neck dissection and you are preserving the spinal accessory, the internal jugular, and the sternocleidomastoid, it comes with some morbidity, which is called known as a shoulder syndrome. So what you have pain, you have limited abduction, you have limited external rotation, and there is disfigurement and drooping. Why this happens is because of the handling of the nerve during the supraomoid neck dissection. When you have to clear level 2 nodes, you have to retract the spinal accessory nerve where it goes into the sternocleidomastoid muscle. During the modified neck dissection also, you have to preserve the spinal accessory nerve, and you have to bare the nerve and remove the lymph nodes and the other lymphatic structures. So there is a lot of handling which happens. Even if the nerve is anatomically preserved, sometimes you hamper the vascularity of the nerve and you have this shoulder syndrome. So what till now we are doing is we are addressing when there is a regional lymph node, and we are removing this lymph node when it gets involved or when there are chances of occult metastasis. Now, if we address the node here, when the sentinel node becomes positive, we can avoid this neck dissection. So this is the basis of a sentinel lymph node biopsy, which again we have picked up from the breast surgeons, and they do it routinely for small breast tumors so that they can avoid axillary dissection, axillary nodal dissection. What we do is we inject a radio tracer. Most of the times it is technetium 99 submucosally in 2 or 4 quadrants in the primary tumor. After say half an hour or 1 hour, we take the patient from the operating room to the gamma camera room, and a SPECT image is taken. Now either it is sometimes only a SPECT or it is a fusion image or a SPECT CT. Now, once you have done a SPECT CT and you have localized the node, the patient comes to the operating room again. We excise the tumor as as oncological safety and with oncological goals. And then we have a gamma probe with which we would look at the activity in the node which has been picked up by the SPECT or the gamma camera. Now this gamma probe will show us the activity on the monitor, and here then we will put a small incision and remove the lymph node. This is how we put a small incision and we put a gamma probe here, and we remove the sentinel nodes which were picked up on the SPECT CT and which showed radioactivity on the monitor when we introduced a gamma probe. All these nodes go to the histopathology department. The histopathologist would then report whether the node is reactive or whether it is positive, and then only you go ahead and do a proper supraomoid neck dissection. So this is how you can avoid doing a neck dissection when it is a neck or a node negative neck. The only drawback about this is it is time consuming. It requires a lot of resources, starting from the SPECT CT or the gamma camera and the histopathologist. So it is not feasible in a high volume setup. So this is my last slide, and this is what we call as a precise model for the management of the neck. It starts from prevention. So you prevent doing a neck dissection if the cancer is detected in the early stage. You have radiology, you have preoperative evaluation, chemotherapy in some cases where you have node which is positive or which is extranodal, and you give chemotherapy before surgery. Some cases we combine immunotherapy with chemotherapy. Surgery is the mainstay, and then comes the post-op evaluation. So this is what is for in the management of neck. Thank you for your patient hearing, and I have finished 2 minutes before.
Yeah.
Yeah. So thank you for your kind attention. I
Thank
can
you.
take questions if you all
Yes.
have.
You may now stop the screen sharing so that we can have question answer. So thank you very much, Dr. Rajesh Bhai, for, as expected, very elaborate, very informative, and still very comprehensive talk on lymph node management. So now the house is open for any questions, discussion.
You gave a lot of stress on capsule, breaking of capsule and within the capsule of lymph node.
Yes, sir. Sir,
So-
because extranodal extension or extracapsular spread directly impacts on the survival rates and the prognosis of the patient. So this is very important clinically when you get a histopathology report and you have to explain the prognosis to the patient and the family. So that is one aspect when you have to explain the prognosis to the family. The other and the most important aspect is when you have extranodal extension, only radiotherapy as an adjuvant treatment would not suffice. So you have to add chemotherapy to radiotherapy. And when you add chemotherapy to radiotherapy, which is a very toxic treatment by itself, radiotherapy, you add to the toxicity to the treatment again. So what happens is you have concurrent chemotherapy and radiotherapy, both which is going on in the post-operative adjuvant setting to the patient. We have seen patients who are on chemotherapy and radiotherapy. There are what you say, they default the treatment because of the toxicity. So radiotherapy, which is the mainstay of treatment, sometimes the patient is not able to finish that treatment because of chemotherapy. So yes, extranodal extension is very important, and we stress a lot on extranodal extension, and this is something which is not in our hands. As a surgeon, you get the histopathology report which shows his extranodal extension. In even nodes which are less than 3 centimeter or 2 centimeters or 1 centimeter in size, you sometimes get extranodal extension also. So yes, it is very important, both prognostically and toxicity wise also.
Rajesh Bhai, you talked about gamma camera in the last part of your talk.
Correct.
For very selective dissection. So in the current setup where you are working, are these facilities available?
No, because this is something which is institutional based. You have to have everything under one roof so that all the whole team and the entire team works as a in sync. So it is very difficult. Even if I procure a gamma probe, as a surgeon, what I need to do is just to get a gamma probe. But just imagine shifting the patient from the OR to a gamma camera setup, then bringing back the patient. It is a lot of effort and a lot of, so only big institutions, and mainly this is done where the breast surgeon or the breast surgery department is very active. So it is something like robotic surgery with how it came into head and neck. The urologist and the gynecologist were using it, and so we started using it for our thyroids and neck dissections. So the same thing is, if the breast department and the breast surgeons are doing a lot of gamma camera and sentinel node, it becomes easier, and the team is also very much tuned and trained to tackle these cases. But again, Satish bhai, what I would say is, most of our patients, when we see them in our clinics and we do the inspection and palpation and the MRI, most of these tumors are thick tumors. There are very, what you say, minuscule group of patients who will come with a very thin tumor, would require a sentinel node. Most of these are advanced cases, thick tumors. And again, the patient compliance is very important. Most of our patients come from far, they are not ready to come for regular follow-ups. So currently we are not doing, it's an institutional practice.
Presentation is usually late.
Yes. And again, if you look at the trials which are done on sentinel lymph node biopsy, the results after 5 years, they say the shoulder morbidity is still there, even if you do a small scar and do a sentinel node biopsy. So the main purpose is not achieved, and the survival and the cure rates and the rates of recurrence are again very high with sentinel lymph node biopsy. So as surgeons, and the patients would also want, we treat the patient in one sitting, and that is something which will upstage the disease also if there is a node positive on the final histopath report.
So what are the current clinical trials you are conducting in this field?
In this thing, most of these trials are in advanced head and neck cancer. So we are currently doing a trial which is for advanced metastatic head and neck cancer. Metastatic in the means regional metastasis in the neck, and for the primary, for recurrent cancers of the head and neck, but not metastasizing in a distant organ. So what we are doing is, we have a immunotherapy drug. There are two arms of this study. One is the immunotherapy drug, which we call as a standard of care arm. So we give this immunotherapy drug to patients who are in this arm every weekly. And there is the second arm where you have the immunotherapy drug injected at the tumor site, and then you do photo immunotherapy. So there is a laser light which you have to deliver after you have injected the patient locally around the tumor, and then you do a laser treatment of these patients. So that is one trial which we are doing. The other is a curcumin trial, or the second primary tumor, prevention of second primary tumor trial, which we are currently doing at Bankers. So this is patients who have squamous cancer of the oral cavity without a node positive on the final histopathology report. So they are stage 1 or stage 2. So we give a combination of metformin and curcumin. One arm, the other arm is a placebo arm, and the other two arms are either metformin or curcumin. So the patient is given one drug there are 4 arms and the patient is followed up. So mainly we want to look at the effect of curcumin when it comes to prevention of second primary tumor after we have treated the first index tumor. So these are the 2 trials which are going on. One trial is we have already written and it is going to come is again for advanced recurrent oral cancer, which is again an immunotherapy drug, which we will start by mid or end of this year. So these are the 3 trials which are going on currently.
Wonderful. I always appreciate the clinical research that you've been doing for so many years now. You and Mrs. Kantharia also. So congratulations.
Yes, yes. All credit goes to our clinical research team, which is headed by Shehnaz and her team.
Great, wonderful.
Yeah.
So if there are not any questions or comments, I think we end the session here. Thank you, Rajesh bhai, once again.
Thank you, Satish bhai and all seniors and teachers for your patient hearing. Thank you all.
Thank you. So we meet next Saturday morning again. We'll have Dr. Arpan Shah, pulmonologist, as our guest speaker next Saturday. So thank you all. See you again.